Hello, I'm Dr. Ken Landau. Thanks for watching. Let's talk about Breo or Breo Ellipta. This is a medicine that was approved by the Food and Drug Administration in 2013 to treat asthma and chronic obstructive lung disease or chronic bronchitis in individuals over age 18. Let's repeat that. Over age 18. That's very important. By 2017, the FDA came out with a warning cautioning that use of this drug might be associated with an increased incidence of hospitalizations and death from asthma. Now, the company tried to get the FDA to consider allowing use in individuals less than age 18. But when the FDA evaluated the evidence, they said, we don't have any evidence of safety, we don't have any evidence of effectiveness, and no, you can't do it. On the other hand, in Australia and the United Kingdom, it's approved for individuals over age 12. The medicine combines two different drugs. It combines an inhaled corticosteroid, cortisone, it's called fluticasone, with another medicine that's a long-acting bronchodilator. It relaxes the muscles around the wind tube, and it's called vilanterol. And these are combined in one inhaler. They are to control stable disease, whether we're talking about asthma or whether we're talking about chronic obstructive lung disease. They are not for use in people who are having a flare of their disease. If you're having a flare, you need to have a rescue inhaler, a short-acting bronchodilator. The cortisone component, the fluticasone, that's a pretty potent steroid, and it works to cut down the inflammatory cells, the cells that make the histamine and the inflammatory reaction to allergies, those eosinophils. On the other hand, the vilanterol, the other component, the bronchodilator, the long-acting bronchodilator, that's the one that seems to be associated with maybe an increased death rate in people who have asthma. Now again, the medicine is only for those people who are well controlled. If the disease flares, use your short-acting bronchodilator. It is inappropriate to double the dose of the Breo. You do not do that. If you have either disease, asthma or the chronic obstructive lung disease, and you find you're using more than one canister of the rescue inhaler every couple months, or you need more than about 4 puffs of the relief inhaler, then you need to get some other kind of maintenance therapy. Now, in asthma, about a third of the people who are diagnosed without any kind of laboratory confirmation that that's indeed what they have. Asthma is a disease where there is a decrease in the FEV1. FEV1 stands for forced expiratory volume in 1 second. So the amount of air you can get out of your lungs in a second. In asthma, the condition is reversible. When the disease goes away, the lungs basically come back to normal. That's as opposed to chronic obstructive lung disease. When you have the emphysema or the bronchitis, it doesn't come back with treatment. What are the symptoms of asthma? Symptoms are wheezing and shortness of breath and chest tightness and cough that vary in frequency and intensity. You go from normal to an attack, and you can go very quickly, or it can be a relatively slow deterioration. It's due to bronchoconstriction and airway narrowing and thick mucus forming in the airways, and that can occur at a moment's notice. It can occur because of a viral infection, or maybe you're participating in exercise, or you're exposed to cigarette smoke, or you're really goofy and you smoke cigarettes yourself. You could laugh or be under stress. Just breathing cold air or consuming a cold beverage is enough to precipitate a flare in some individuals. And certainly if you're given a beta blocker for high blood pressure, that can cause a very severe flare very quickly. Now, in asthma or in chronic obstructive lung disease, like I say, the deterioration can occur very rapidly, and a lot of people, unfortunately, have a tendency to believe that an extra inhalation of their Breo might be okay. It's not okay. Don't do that. Now, if you have asthma, the standard mild asthma, a short-acting bronchodilator is going to be quite sufficient. The Ventolin or the albuterol, that's all you need. Relatively simple kind of medicine. If you have more than 2 attacks a month, if you wake up at night with asthma or because of asthma more than once a month, or if you have other precipitating factors, then you might consider that you need something more than the short-acting bronchodilator. So we have the step-up therapy, and the step-up therapy is that we'll prescribe an inhaled corticosteroid, a low dose. And if you're a little bit worse, we'll use a moderate dose. And a little bit worse, then we'll use a higher dose of inhaled corticosteroid. And then, if necessary, we'll use a long-acting bronchodilator. That's when the Breo might come in. Breo is not a first or second choice as far as most asthma is concerned. So the step therapy, short-acting bronchodilator, Ventolin or albuterol, that's the first choice. If you're a little bit worse, the inhaled steroid, low dose, then moderate dose, then high dose, then with the long-acting bronchodilator, the Breo. And then if it's still bad, there are a variety of other medicines that can be used again. Well, if we're talking about asthma, there are 2 different strengths of Breo Ellipta that are available. Both of them contain 25 micrograms of the vilanterol. One of the inhalers has 100 micrograms of the steroid. The other one has 200 micrograms of the steroid. But remember, the amount of vilanterol is exactly the same in both containers, so the containers are not interchangeable. Very important to realize that. And always have a rescue inhaler at hand just in case you happen to have a flare. So whenever you get the prescription for the Breo, make sure you get the prescription for the short-acting bronchodilator. Now let's talk about chronic obstructive lung disease. Chronic obstructive lung disease is extraordinarily common. About 13 million people in the United States have chronic obstructive lung disease. And it's estimated there are probably about another 20 million who are undiagnosed. The World Health Organization says that by the year 2030, it's going to be the 3rd most common cause of death. And probably somewhere between 30 and 75% of the people who have the diagnosis are not on therapy. And a recent study in 2018 from the American Journal of Medicine suggests that probably half of the general practitioners, of the family doctors, primary care doctors, are not aware of the current guidelines. They're called the gold standard. Well, if you're over age 40, you have about a 10% chance of having chronic obstructive lung disease. If you're a smoker, it increases to about 20%, increases further if you're a heavy smoker. And it's not just cigarette smokes. If you have a history, mom's side, dad's side, of asthma, then you seem to be at greater risk. If your mother was a cigarette smoker and your lungs were exposed to the cigarette smoke when you were young, you have an increased risk. And if you had a series of respiratory infections as a child, increased risk. Chronic obstructive lung disease is a persistent airflow obstruction. Remember, in asthma, it's reversible. In chronic obstructive lung disease, it's treatable, but it's not reversible. The primary therapies in chronic obstructive lung disease are a long-acting bronchodilator or a long-acting anti-cholinergic. Inhaled corticosteroids are not a primary treatment. Now, if we look at the people who are being treated in the United States right now, a significant percentage of those people are not treated by the current guideline standards. As an example, in one urban hospital, looking at 100 people, only 2% were being treated according to guidelines. And when the people were followed up, a month later, only 25% were getting guideline-approved therapy. What are the symptoms? The symptoms can vary from day to day. Remember, it's a chronic progressive lung disease with cough and sputum production and wheezing and chest tightness. And when you don't get enough air, you get anxious or depressed. You have a decreased quality of life. And still, people are being treated with inhaled corticosteroids. But the benefits are overestimated, and at least current guidelines suggest you have to have really advanced disease prior to the time you should be using an inhaled corticosteroid. Well, if you have mild symptoms, if your FEV1, the forced expiratory volume 1, is between, say, 60 and 80%, chances are you might be breathless with moderate exertion, maybe get some recurrent infections every now and then, but it has little or no impact on your quality of life. As the disease further progresses, and remember, unfortunately, it's a chronic and progressive disease, and now your ability to get the air out in 1 second is only 40 to 50 or 60% of normal. Now you're going to have some difficulty walking even on level ground. You're going to have limitation of your normal activities. You're going to frequently have cough and sputum production. You're going to have flares that are going to require some oral therapy. And as you get even more severe, with an FEV1 of less than 40%, so you can only get at less than 40% of what a normal person can get out in 1 second, then you're going to be very severely affected. You're going to be breathless all of the time, and you're not going to have any quality of life. And unfortunately, you're not going to be able to get around, not going to be able to walk. You're going to be mostly housebound. Now, what's the treatment? The treatment is, if you have really mild symptoms, a short-acting bronchodilator, just like we were talking about with asthma, or a long-acting bronchodilator would be quite appropriate. As the disease gets a little bit more severe, certainly the long-acting bronchodilator. And if you happen to still have symptoms, we add the long-acting anti-cholinergic. And then as you further deteriorate, then it's appropriate to consider adding the inhaled corticosteroid. That's when a drug like Breo would come in. But remember, the Breo is a long-acting bronchodilator with the steroid. In the treatment of advanced chronic obstructive lung disease, we need the long-acting bronchodilator plus the long-acting anti-cholinergic, and then consider the steroid too. And then if you happen to be even worse, we have additional medicine that might be appropriate. But the important thing is that 2/3 of the primary doctors and 1/3 of the respiratory specialists are not using the current guidelines for treatment. For some reason, people believe that the treatment for asthma should just be copied onto the treatment for chronic lung disease. The two of them are different diseases. They are completely different and need different kind of principal therapy. Well, if we look at how a medicine like Breo does in a person who has chronic lung disease, and we look specifically at the impact on the quality of life using the St. George Respiratory Questionnaire, it seems that whether you use the Breo, whether you use the fluticasone, that's the cortisone, whether you use the Vilanterol, that's the long-acting bronchodilator, whether you use a placebo, they all have the same effect. They don't seem to change the quality of life significantly. Now, if you are using the medicine, if you're using Breo, remember, you don't add another long-acting bronchodilator. You stay away from the beta blockers, the drugs to treat high blood pressure. You don't use it more than it's been prescribed. You don't take an extra dose. If you have acute bronchospasm, then you need the short-acting bronchodilator. And if you have very severe asthma, this is not an appropriate drug for you. Does it have some side effects? Does Breo have some side effects? Sure. Every drug has side effects. Make your nose run, give you a sore throat, hoarseness, mouth or throat pain. Some people can cause a headache. Other people complain of confusion. Since it has a steroid, it can increase the likelihood that you're going to develop yeast infection of your mouth. So after you use the medicine, you ought to rinse your mouth. It may lead to an increase in lung infections, in pneumonia. It could have an increased incidence of raising your blood pressure or raising your heart rate. That seems to be the Vilanterol effect. It can work on a weakened immune system to weaken it even more so that you might get some infections. It could be bacterial or viral. Could be fungal infection. It can decrease the adrenal function. So especially if you were taking oral cortisone and then you switch to the inhaled cortisone, well, that might precipitate a crisis in your adrenal gland that could theoretically be life-threatening, so you do have to be cautious about that. And suddenly, after starting the medicine, because of the volanterol, it can give you some tremors and some restlessness. Steroids can thin the bones, and they can cause an increased incidence of cataract and glaucoma. They can increase the blood sugar or the potassium, stunt your growth. And paradoxically, when you use these inhalers, they might cause bronchoconstriction. They might cause a spasm of the bronchial tubes because of the particulates. You have to be careful if you happen to have hyperthyroidism when you're taking these medicines. Well, it's very important to realize that if we look at prolonged use of the medicines, then we have a series of problems that may develop. And one of the problems that can develop if you haven't reached maturity is the steroids seem to be associated with a stunted growth. So if you're not at full height, for every year you use the medicine, they might stunt your growth by about a centimeter. And the volanterol specifically, well, since it stimulates the nervous system, if you happen to have coronary insufficiency, you have coronary arrhythmias, you have hypertension, can worsen the situation. Is it possible to overdose on this stuff? Not on the steroid part, but on the volanterol, yes, indeed. You could develop angina, high blood pressure, your heart rate can go up, you can have palpitations, it can cause you to be nervous, cause you to have some muscle cramps or insomnia, even can cause seizures. Not studied in pregnancy, not studied in lactating women, not appropriate for individuals less than age 18, but it is okay if you happen to have mild kidney disease, probably not if you have significant liver disease. If you're taking other kind of medicines by mouth, then that can interfere with the fluticasone. Using the medicine is relatively simple. It comes in an inhaler. You take a deep breath out. You put the medicine between your lips, close your lips around, inhale through your mouth, not your nose. Inhale through your mouth, hold it for about 3 or 4 seconds, and then you can breathe out. There are a variety of inhalers on the market. Is there any obvious difference between them? Maybe not as much as people think. Are there other medicines available? Well, you could take the long-acting anti-cholinergic, that's umeclidinium, say, or thiotropium. Those medicines are available. They're very helpful in people who have chronic obstructive lung disease. The Breo Ellipta is a combination of one of those long-acting anti-cholinergic with a long-acting bronchodilator. That seems to be gaining a lot of traction right now in people who have chronic obstructive lung disease. That's easily available with a prescription. If you wanted the Breo Ellipta, well, it's kind of costly. If you paid cash, it would be somewhere between about $370 and $450. If you had a coupon, maybe as low as $350. But it's expensive. So the bottom line is, when we're talking about Breo, it's highly overused, a lot because of all the television commercials that have been on. It's not only overused, but it's misused, because remember, in asthma, the primary therapy, mild disease, short-acting bronchodilator, moderate to severe disease, the inhaled corticosteroid of different potencies, and then add the long-acting bronchodilator, and the steroid and the bronchodilator, that is Breo. And if you happen to have chronic obstructive lung disease, well, the primary therapy is the long-acting bronchodilator, not the inhaled corticosteroid. But irrespective, if you happen to have asthma or if you happen to have chronic obstructive lung disease, make sure you don't smoke cigarettes. You should get a flu vaccine. You should get the pneumonia vaccine. You should eat right. And you should exercise. And if you do that, and stay away from the cigarettes, just stay away from those things. If you do that, hopefully, you'll be okay. Thanks for watching. I'm Dr. Ken Landau.